I am Vinnie Tortorich. Folks, your good intentions have been stolen, but don't worry. I'm here to help you get them back. You may be soft and succulent at the beginning of this process, but hang in there. Before long, you will be lean and mean, guaranteed. It's the Friday show. You know what that means. We bring someone in with a lot of knowledge. And man, this is a subject I get a lot of questions about, and I just don't have the answers. And look, we're going to bring her right in and get right into it. She's been on the show several times before. I'm talking about Dr. Laura Buchanan. Hey.
Hey, good to be back. Thanks for having me again.
Laura, look, for some reason, people think I have a thing against doctors. So let's start right there. They'll go, oh, you hate doctors. No. Oh, hell no. Doctors have saved my life on more than one occasion. And I'm not saying that, for real. I mean, I would have been dead without chemo. And that's a problem I have. Sometimes people go, hey, we know you wrote this book about eating right and cancer. My mom just got diagnosed with stage 3, blah, blah, blah. What can she eat? Fuck eating, man. Get to a doctor, right? Eat something on the way to the doctor. And then we could talk about, your diet should be just spot on when you have any kind of problem.
Yeah.
Not just cancer. But sometimes there's a time for medication. I do, we just had your buddy, Trochalazian on a couple of weeks ago. And every doctor I talk to now, and I was just talking to a doctor, I was at a funeral this past weekend, and I'm fascinated with what I'm hearing now. 10, 12 years ago when I started this podcast, people were on between 5 and 7 medications, meaning daily they're taking 5 to 7. And Tro says, 20 is not unusual now. And I thought that it was like, that sounds like a bit, this is maybe a little hyperbole, maybe a little bit. I went home and asked another doctor, friend of mine. I said, the guy was at the funeral. I said, hey, I was a good friend, Trochalazian, on the podcast, 20 meds. He goes, oh, yeah, it's not common, but it's not unusual.
Yeah,
right?
it's pretty crazy. I actually, for a presentation I was doing patient cases, at the end of it, I was just looking back at one, and she was on 10 different medications. And
Yeah.
she had been told by her other doctors that she was going to be on these 10 medications for the rest of her life. And within 6 months of a low carbohydrate ketogenic diet, and then by the end of the 6 months, she had incorporated a little bit of exercise too, but she was off 8 out of 10 of those medications.
Yeah.
Yeah.
Yeah, it's just amazing. And another thing that happened, and I'm going to talk about this on another show, probably coming up Monday or Tuesday when I always do a breakdown. Whenever I go down to Southern Louisiana, I come back with a whole breakdown. But I was with someone in a restaurant. I'm just giving just a little lead in here. I was with someone in a restaurant, and we were leaving, and his friend called my friend over, and he goes, hey, you got a minute? He goes, yeah. He goes, can you sell me some of your Manjaro? People are selling Manjaro. They're selling GLP-1s. And I said, why can't he get his own? He goes, oh, he has some. He's doubling down. People are doubling down.
Interesting.
Did you know that? I mean, they're selling their drugs back and forth to each other.
I mean, I can absolutely believe it. You hear about things like that fairly commonly in the college world with medications like Adderall or other stimulants. And
Right.
so the GLP-1 medications are extremely expensive. And for many people, it's a total barrier. And so if their friend was able to get them a half price or some other deal, then I believe that would be happening.
Well, my understanding is that this guy had something coming up and wanted to double down. And by the way, the dose that they were both on at the time was the 15 milligrams because I asked, I had to know.
Yeah.
And that's the big dose, right?
Yeah.
Yeah, that's the killer dose. And this guy's going to now double up. with no doctor's permission or anything else, you know. So it's kind of nuts at what's going on out there.
Yeah, it is a little bit of the Wild West, which is unfortunate. And I actually, someone, it was yesterday, someone told me, yeah, my friend's taking 20 milligrams. And I was like, are you sure about that? It's, 15 milligrams is typically where we cap out. And they said, no, I'm pretty sure they're on 20 milligrams. So I guess that is the self adjustment and, trying to get
Yeah.
more results through it.
Yeah, it's all nuts. And, you know, we're at 20 now. And if this podcast goes on for another 10 years, we might be talking about 30 drugs because people don't ever seem to go, the number is not going down. The trajectory is up. Just
Yeah.
let's just throwing more and more chemicals. And it makes you wonder how the body, the liver, you know, how it can handle all of this.
That
Just all of it,
it
right?
is a wonderful question. I mean, a lot of the studies that are done on these medications are not done on people on a set of 10 different medications. So when you throw that all into the body and it has to process it, we really don't know how everything is interacting together. But I mean, there are times where you'll deprescribe certain medications, whether it's a beta blocker someone really doesn't need after a heart attack because their heart function is still good. And you stop that medication, all of a sudden their fatigue is better, their blood sugars are improving. And, we see side effects from medications all the time
Right.
that some of them are known and then some are definitely unknown.
Yeah, I complained about this out loud on the podcast. You know, I had to go back on chemotherapy last summer for the same cancer that I had 17 years earlier. And they gave me exactly the same chemo, except this time they gave me 2 antibiotics to take. And I said, why am I taking this? They said, well, we now prescribe this along with that therapy because you could get an infection and die. And I said, well, I didn't take any of this 17 years ago. I said, yeah, but now this is what we do, protocol. And I said, can I refuse to take them? No, you have to take them. Okay. So I start taking the 2 medications with the deal. And it gave me, within 2 or 3 days, I had a rash, like my whole body, face, scalp, everything except the palms of my hands and the bottom of my feet was one big whelp, just
Ooh,
covered.
yeah.
And I said, hey, doc, you know, this is what's going on. Oh, okay, you're going in for your chemo today? Because I have to go to chemo every day. It's like, yeah, stop at the pharmacy in the hospital. They'll have something for you. Take X amount of it right there. The pharmacist is going to hand it to you. Take it right away. They handed me cortisol or one of those
Steroids.
steroid things,
Yeah.
and a large dose, and I pop it. And by the time I got through, you know, I had to sit there for 4 or 5 hours to have it dripped in, have the chemo dripped into me. I was jumping out of my skin. I was nervous. I was, you know, I was upset when I was driving myself home. I started yelling at someone in the car. You know, like I never have road rage. I'm not that guy. This was an immediate reaction. That night I couldn't fall asleep. You know, just this whole thing. So I called the nurse bright and early the next morning. I couldn't wait for daylight to call the nurse. And I said, listen, you guys gave me a drug prophylactically to go along with the chemo. The drug had a horrible reaction. Instead of taking me off of the drugs, you guys gave me a drug to fight the horrible reaction. It hasn't helped so far, but I can't sleep at night, and sleep is probably the most important thing I can do
Yeah.
with cancer. She goes, you're correct. And I said, so I know I'm on the phone with you, so I'm guessing the next thing you're going to suggest is that I take a sleeping pill to go along with the drug you gave me for the other drug I didn't need. And she goes, that's exactly what we're going to do. I'm going to get the doctor. I said, no. I'm not taking the sleeping pill. I want to know how quickly I can titrate off of this cortisone that I've only taken twice and this other crap that I've only taken for 4 days, because I'm not going on any more drugs. I'm going off of drugs.
Yeah.
And she goes, let me talk to the doctor. I got a call in 20 minutes. She goes, the doctor says you could go off of all of them. All of them. All of them. So you see what I'm saying? Anyone who's not me, anyone who won't question what's going on, anyone who didn't have this cancer before and took the same cladribine or whatever that drug was called, wouldn't know to ask these questions because I went through this before and didn't take any of these other drugs. Right?
Yeah.
I sailed, well, there's no sailing through chemo. Okay. But in chemo terms, I sailed through after that.
Yeah.
All of the other drugs, Laura, didn't need them. What say you?
It's the prescription cascade, which unfortunately is all too common in medicine. You prescribe one medication, there's a side effect. You prescribe another medication to counter that side effect, and it really does happen. I mean, many times. That's where the deprescription can be very fun, and I really enjoy that aspect of my job because patients are not always aware, because why would they be, that the medications they're on, and some of them are because of side effects from other medications they're on. So if we just stop the medications, change their lifestyle a little bit, they don't need those medications in the first place. And so I'm sorry you had to go through all of that. That sounds terrible, but I'm glad you were able to advocate for yourself and kind of stop that.
Look, that's the thing. I'm me, right?
Yeah.
I've been yelling about stuff my whole life. It's what I do. Most people wouldn't think through it. They go, well, the doctor is, the doctor knows. And as you know the old saying, the person who finished top in your class and the person who finished last are both called doctor. Now, my doctor wasn't a bad doctor, but this is what doctors do. Oh, you have a problem with the drug we gave you? Let's not. And most people wouldn't say to the doctor, hey, I'm going off of these. The only question I have is, I know that you have to titrate off of some of these drugs. And he said you weren't on long enough to have to titrate. Just go off.
Yeah.
Just go off. Why couldn't he say that at the beginning?
Yeah.
Right?
It's unfortunate. I think truly this probably happens more commonly than we think. I can't remember the statistics, but the number of people that are hospitalized per year due to medication adverse events or side effects is significant, actually.
Yeah, it drives me nuts. The real reason I wanted to have you on today was to talk about the Women's Health Initiative and hormones, because I get that question. Most of my clientele is older. Everyone that listens to me on the podcast, yeah, we have some younger people, but we have an aging population. And those, for some reason, those people have glommed onto guys like me and they just want to know the truth. Right. And, look, we have a lot of people in their 30s and 40s that pay attention. A lot of women going through perimenopause, pre, peri, post. There's so many menopauses now. When I was a kid, it was just called the curse. And then, that was it. Right now, we got all these different things. Before we do that, let me do this, folks. PureVitaminClub.com. That's right. PureVitaminClub.com is the purest vitamins on the planet. I know that because I own the company. Some of you may have stopped for a while because I had someone running my company pretty much into the ground, but I took it over. And I see all of the great comments now. And I love seeing the comments on X when people are going, hey, I ordered and everything showed up on time. And I get it. Every now and again, you'll hear, hey, I ordered, everything showed up except my zinc or whatever. When you're shipping out tens of thousands of products per day, even Amazon screws up something. So, but all in all, we get the products out every day on time, and you guys can enjoy the best vitamins on the planet. There's no excipients, flow agents. I control the entire company, so you can trust what you're getting in that capsule. PureVitaminClub.com. Go there, get all of your vitamins. And we're talking to Dr. Laura Buchanan. Laura, hormones. Guys ask me more than women. I'm going to just be honest. And I don't know if you know much about that, because every guy, every doctor is telling every guy you have low T and you need to be on TRT or HRT. But I think HRT is more for women.
Yeah, hormone therapy is more the classic term, or now the term has actually switched from HRT to just HT, but hormone therapy for women and TRT classically for men, although women actually have more testosterone in their body than estrogen, which many people, even doctors, do not realize that. So testosterone is not just a male hormone. It is, again, women have more testosterone than estrogen in their body.
Okay. So who needs this? Do they need it? Where are we on this?
So just a little backdrop, because we were just talking about medications and prescribing cascades. And so in general, I do not like prescribing medications. When I can, I try to get people off of medications. And I myself do not hardly ever take medications, even ibuprofen or Tylenol. I just prefer not to. Now, when it comes to hormone therapy, which is something I have really started learning and studying a whole lot in the past 3 years on my own, because it really was not taught during medical school or residency, except that during medical school, we discussed the Women's Health Initiative that we'll get to in just a second, that basically scared us from hormones, said hormones are dangerous, don't prescribe them unless it is absolutely, absolutely necessary. And that was about the extent of it. They're going to increase your breast cancer, increase stroke, cardiovascular disease, all these very scary things. And so when they actually they did a survey of residency programs looking at internal medicine doctors, family medicine doctors, OBGYNs, who you think would specialize in women's health. Only about 7% of residents felt they were adequately prepared to manage women during menopause or during the menopause transition, which is crazy, only 7%. And 35% said they wouldn't even prescribe hormone therapy if women were symptomatic, dealing with lots of symptoms, and had no reasons not to take it, no contraindications. They still said they wouldn't prescribe it. So this is an area that unfortunately still, from a medical standpoint, although it's very popular now in the news and social media, people talking about it, still on the medical side, we are behind. We are stuck back in the early 2000s with the Women's Health Study.
Okay. So the study, kind of like what we did with people like Ansel Keys and everything else, one bad study shows something, where the statistics won't hold up. And then we start making decisions based on one bad study. We can say the same thing about saturated fat. We can say the same thing about a lot of things, right?
Exactly.
And when you go back and you get a Nina Teicholz in there, goes back and reads all of the studies and go, wait a minute, that's not exactly what it said. But, let's take that sort of thing. Nina can go in and go, saturated fat, it's not bad for you. It's actually good for you. And then you'll get a vegan doctor that'll go in there and go, no, it's really bad for you. So, and we see it with politics, right? The left are going, what are they doing? And the right are going, what are they doing? Everybody is yelling at each other in opposite directions. Why should we believe you?
So let's talk about the Women's Health Initiative to figure out why pre-Women's Health Initiative, over 40% of women were on hormone therapy. After that study came out, depending on which statistic you look at, less than 5% of women are on hormone therapy. So it got dropped hugely overnight, basically. So in this study, they had over 16,000 women that they put into 3 different groups: placebo, and estrogen, which was conjugated equine estrogen, so Premarin, which comes from horse urine, plus medroxyprogesterone acetate, which is a synthetic progestin. And so you either got that combination of estrogen and progestin, placebo, or if you did not have a uterus, so you did not need the uterine protection from the progesterone component, you got just the conjugated equine estrogens. And then they followed these women, and after about 5 years, there was a press report. So this actually, even before the data was published, before doctors could review the data, there was a
Right.
press release in 2002, which this never happens for any research, saying hormone therapy increases breast cancer by 25%. And
Wow.
doctors were panicking, people were panicking. That's huge. And this came out as a press release again, so no one can see the data that is leading to this press release from the NIH. Well, a week later, the data is published. People are looking at it, people are analyzing it and seeing what's really going on. That 25% was a relative risk And so when you look at the absolute numbers, it went from 4 out of 1,000 women to 5 out of 1,000 women. So a 1 out of 1,000 people
That's a
increased risk. So
25% increase. Yeah, yeah.
yep, so that's a 25% increase, but it's really 0.1% is the absolute increased risk. And that was in the group that got the oral Premarin plus medroxyprogesterone acetate. And now there has been numerous studies since this that have come out saying medroxyprogesterone acetate, which is a synthetic progestin, which we rarely use now at this point, has been shown in numerous studies to increase breast cancer risk. The risk is still not huge, but it's been shown time and again to do it.
Right.
So because of this study and those results, estrogen, all estrogen products, got a black box warning saying estrogen increases breast cancer risk. Well, what the study did not mention, or they did not mention in the press release, if you looked at the estrogen only arm in this study, they actually had a decreased risk for breast cancer. It wasn't
Right.
huge, but it was there. And so that's the first kind of glaring flaw, statistical, I would say, manipulation. They had an agenda. They were trying to scare people. They had a press release before doctors could look at the data. And the preconceived notion was that hormone therapy is dangerous. And then this confirmed that.
Right. Okay.
And so, yeah.
So now we've come around completely, somewhat. Where are we now?
So there has been multiple reanalyses of the WHI. And the other thing, going back just a little bit more about that population and the types of hormones that were used in the study, because it's very important.
Mm-hmm.
So on average, the women were 63 years old, and they're, for the most part, asymptomatic because they didn't want to put women on hormones that were having hot flashes or symptoms where they would know if they got hormone therapy that you couldn't tell, they would know it was not a placebo. So
Right.
they basically took asymptomatic women who were more than 10 years after menopause and randomized them because the goal of the study was to see, does hormone therapy decrease heart disease risk from a primary prevention standpoint? So that was the goal of the study. And the type of hormones they use, again, we don't really use anymore. It was an oral synthetic estrogen, and all oral estrogens actually increase clotting factors. And so the other black box warnings that got put on estrogen was that estrogen increases clot risk, increases stroke risk, and possibly increases dementia risk. So again, when you look at those absolute numbers, it was about less than 1 in 1,000 for each of those different risks, less than 1 in 1,000, 0.5 in 1,000. So they were there, but they're very small. And that was using a synthetic oral estrogen where we know oral estrogen is metabolized by the liver to increase clotting factors. Now, most of the time, some women still can use oral estradiol, which is bioidentical, which we can talk about. But
Mm-hmm.
and if they're very low risk, again, it's not a huge increased chance that they're going to have a DVT or a blood clot. But if you use transdermal estrogen, you totally bypass that. You don't increase clot risk. There are not studies showing you increased stroke risk. And there's also not studies showing an increased dementia risk. In fact, there are some studies showing a decreased risk of dementia.
Who's doing the study? Is this the inmates running the asylum, or because a lot of times drug companies run their own studies? Who's doing these studies?
Yeah, so it was a large group of individuals actually, and Joanne Manson was the lead on the study, who actually she's been the most vocal about coming around and explaining a little bit of reanalyzing the data, but acknowledging some of the flaws that were inherent to the study. And so it's interesting because it was not, there are some conspiracy theories about, well, Big Pharma prefers us not to use hormone therapy because it doesn't make them a ton of money. And if a woman does not get hormone therapy, then she's going to have sleep issues. She's going to have depression. She's going to have hot flashes. She's going to have, 4 other symptoms that I can give her 4 different medications for.
Yeah, pay me now, pay me later. Yeah, I'd
Yeah.
rather. Yeah.
Yeah.
Yeah, you hear that, but yeah, again, that's conspiracy thought. Yeah, it's like you hear that stuff, and we
Yeah.
can't substantiate any of it.
Exactly.
So,
No, not at all.
what are the risks involved with taking these injectable estrogens?
So injectable estrogen is not very common. There are pellets. Some people do use. I
Right.
prefer not to use pellets for testosterone or estrogen because once it's in, you're kind of stuck with whatever the levels are going to do until the pellet basically runs
Or
out.
what's that? Yeah.
And so I have seen patients who they come to me and they're seeing someone else and they had a testosterone pellet placed and their testosterone is 400 and 300, which I mean, these are men's level ranges of testosterone
Right.
where you can really worry about potential side effects called variolization, where you can get Adam's apple developing, voice changes, clitoral enlargement,
Right.
acne, hair growth, many side effects that you would not otherwise expect to see if you're doing physiologic dosing of testosterone for women or estrogen.
Okay. I'll bring up this. I won't mention a woman's name, but there was this woman. I go rowing at the rowing club down the street, right? And it's me and a bunch of older women. I guess they have time to row. And I met this really nice woman. She's one of those Southern belles, right? She's got the nice drawl and everything, and gorgeous woman. She's got to be 70, 72 years old. And she saw my stature one day and she goes, obviously you lift weights. And I said, yeah, I hit the weights a bit. And, so we got into a conversation while we were, wiping our boats down to put them away. We were there at the same time. And she said, yeah, I lift weights too. I got back into it about 4 or 5 years ago. And I was, oh, that's great. It's, and you're out here doing this and you're lifting weight. This is all great. We're having a, and she goes, I thought my life was over with when I was in my early 60s. And I said, why is that? I thought she was going to talk about cancer or something. And she goes,
Yeah.
I didn't care if I lived or died. And then I got on these hormone therapy. And she mentioned taking 2 or 3, I take progesterone this, testosterone that, estrogen the other thing. Like
Yeah.
4 or 5 of different things. And she's always on my mind. It's like, wow. But whatever she's taking, and I think she had mentioned, and you're halfway listening when you're trying to get out of there and you're putting a boat away. But she got my attention. She mentioned, at first I was doing this and it wasn't really working, and then they did that. It was some trial and error, I guess,
Yeah.
is the point I want to make. And she said the last 2 or 3 years of her life since she started doing all of this stuff, she goes, everything is better again. I feel like I'm young again. I feel like. So what are we talking about? What are all these drugs she's talking about?
Yeah. So it really is remarkable. That's, I think the two things I love were in regards to practicing medicine, helping people change their lifestyle, eat low carb, increase physical activity, several pillars of health. But then hormone therapy really has become another piece because it is just so impactful for many women and improving their quality of life like nothing else. And so she sounds like she was probably on all 3 of the major hormones, which would have been estradiol, progesterone, and testosterone replacement.
Okay.
And and
Go.
so yeah, so again, kind of going back to the WHI, one of the big things that came out of it was you should not prescribe hormone therapy after the age of 60. Well, again, that was the flaws with the type of estrogen, the type of synthetic progestin that showed increased risk, potential increased risk of dementia if you're starting in women over the age of 60, which again has not really been shown in other studies. We need more studies, truly, of using bioidentical hormones, using transdermal preparations that do not have these same increased risks because of the increase in the clotting factors and the inflammatory molecules that the oral products do cause in our body. But jumping back to her, there are several different ways to provide hormone replacement. And so you can use, when it comes to progesterone, the most common route is micronized progesterone. So again, bioidentical meaning it looks just like the molecule our body creates. It is not one of these synthetic progestins, which there are tons of pills that are synthetic, and they all have what we call off-site reactions. They bind to androgen receptors, they bind to cortisol receptors and other receptors in our body, which is why they cause all these side effects. And again, they increase breast cancer risk, whereas bioidentical micronized progesterone has not been shown to increase breast cancer risk. So she's likely on an oral progesterone. That's the most common. You can use it either through the skin or vaginally. Those are not FDA approved, but some people will do that because not all women tolerate oral progesterone. For some people, it causes negative impacts on their mood. And so if that's the case, again, there are some alternative routes. The progesterone, one of the biggest things people really do like about it is often really helps with sleep quality. And then when it comes to estradiol, there are tons of different ways to do it. I really like using the patches because you put on a patch, you change it twice a week, and you basically forget about it. So it's very convenient for patients. You can also do a daily cream that's transdermal or a gel. There's even sprays that you can apply. There's also something called the Fem ring, which is a ring you insert vaginally and it can stay there for 3 months. One of the potential downsides with the ring is women sometimes note it feels like the estrogen actually wears off by 2 months rather than 3 months. And so your hormone levels start going down again and symptoms can recur while you're in this, waiting period. And it can be pretty expensive. So you may not want to refill it a month early every time.
Got it. Okay. Which brings up my next question, the cost of all this. And does insurance cover it, or where are we on some of this stuff?
Yeah. Thankfully, insurance is usually very good about covering hormone therapy for peri and postmenopause. And the FDA approved indications are moderate to severe vasomotor symptoms, so hot flashes, which over 80% of women, around 80% of women, deal with hot flashes during kind of the menopausal transition. And hot flashes, just a little bit more about them. Some people think, oh, they just get hot and red for a second. They can actually last for a couple of minutes. You can break out in a very like an intense sweat. They can cause feelings of impending doom and anxiety and palpitations that can occur with them. So they're a full body response. It's not just a flash in a moment of time. And some women may have these more than 10 times per day. So they can be very interfering with life. You can imagine you're giving a presentation at work and all of a sudden you have a severe hot flash. Like that could be totally mess with your quality of life and impact your ability to work. So the where was I? Got sidetracked on the hot flashes.
Well, we were right in the middle of who should take it and how they can get it from their healthcare providers and what would it cost.
Yes, costs, exactly. So for perimenopause, the FDA approved indications, moderate to severe hot flashes, moderate to severe genitourinary syndrome of menopause, if they have other indications. So genitourinary syndrome of menopause, something maybe we can talk about a little bit later, that's also very serious that almost all women will deal with, is basically the constellation of urinary symptoms as well as vaginal symptoms that come with the loss of estrogen. So we're talking about pain with intercourse, discomfort, itching. The tissue actually just gets smaller and you have less sensation, so there's less arousal. There's decreased libido. There is urinary urgency, frequency, having to pee multiple times during the nighttime can occur. And there can also be just even discomfort with wearing tight clothing or during exercise because you're just aware of that thing. It's like, imagine if you were just constantly aware of your elbow that was slightly uncomfortable and you just thought about your elbow all the time. It'd be terrible. And so over 50 million women deal with this. And what's crazy is over 70 women have symptoms of this out of 100, 70 out of 100. 25 out of 100 will mention this to their doctors, and only 7 out of 100 will actually get treatment for this. And the treatment is so simple and it's so life-changing. It's vaginal estrogen. I mean, it's cheap. It is cheap. You can use it as a cream or a tablet or a ring that's a lower dose ring than the systemic estrogen therapy. And it is life-changing. So, I mean,
just that can make that quote unquote elbow pain go away.
Entirely. It rejuvenates the tissue. We have estrogen receptors and androgen receptors, so testosterone, all over our urethra, our vulva, our vagina, and our bladder. And so it can take away the urinary symptoms, the vaginal symptoms, the pain with intercourse. And you can imagine how impactful that can be, again, from a quality of life perspective. So it's huge. And people are just, and one of the crazy things is the vaginal estrogen, which is only local, does not increase systemic levels, really, once you're using on that maintenance dose. The black box warning is the same for systemic estrogen. It says that local estrogen that you're applying on your urethra can increase breast cancer risk. Baloney. There's no data to support that. And women who have had breast cancer, they can still use it and they're fine. There's no increased risk or concern.
So you would think that all 70 out of 100 women should rush right out and at least do that, right?
100%. Yeah.
And is that prescription or is that something that's not an OTC, is it?
No, it is a prescription. And again, it's just vaginal estradiol cream, tablets, or a ring. And it's very cheap. If your insurance doesn't cover it, there are good RX coupons where you can get it for a really reasonable price,
Right.
$30 for a couple months supply.
Wow. Yeah,
And
that's good. If there's no side effects to it, then it's kind of a no-brainer,
it is a
right?
no-brainer. And it's what's crazy is one of the things they say if a woman comes in and tells you she's having pain when she's intimate with her partner or she's having all these urinary symptoms, tell her to use a moisturizer or a lubricant. And it's like that's not treating what's causing her symptoms. It may help a little bit during the act, but it's not treating anything. If you give vaginal estrogen, you bring it back to like premenopause where you don't have to worry about that. Maybe you still use some lubrication and that's fine, but you're treating the underlying cause. And women after menopause, they also have a significantly higher risk of UTI. And there's been studies that have shown if you give basically postmenopausal women who qualify for Medicare vaginal estrogen, it would save the U.S. government or insurance $6 to $22 billion per year
Wow.
on UTIs just using vaginal estrogen.
This is kind of unbelievable. And
Yeah.
the risk of side effects very low or non-existent, it seems like. And
Yeah, very minimal. Sometimes, if a woman has been dealing with symptoms for a long time and their tissue has just become incredibly sensitive and tender, then there can be some irritation or pain with initial application just because, again, it's so sensitive, but that will heal and that will get better.
interesting. Quick break, and then I have a few questions about other, I guess, over-the-counter things that people ask me about. You see, I get these questions, I jot them down, then I wait for people like you to come on. Folks,
Yeah.
the one thing you might want to use until you get that estradiol is some Villicapelli olive oil. No, I'm just kidding. Don't do that. It's probably not healthy to put that down on your hoo-ha. But if you want to put it in your mouth, that's a good thing. Villicapelli olive oil is the best olive oil on the planet. I'm not making this up. I'm not saying it because they send me a check every month. I'm saying it because it's true. It's the only olive oil I use in my own kitchen, period. Why? Because it's real olive oil. In this country, you could cut olive oil up to 40% and still call it 100% pure olive oil. I'm not making that up. Go look it up. Google that shit. Go look at chat GBD. Go look at whatever you want to look at. AI. Google AI. Go look at all of them. I'm telling you, you could cut olive oil up to 40%, still call it olive oil. Not with Villicapelli. I'm telling you, it's the real stuff, and they're not charging you an arm and a leg for it. A 3-liter 10 is like 95, maybe $100. Don't quote me on it. But if you bought that, think about it. If you go to one of those fancy schmancy wine and cheese stores and got yourself some olive oil, I guarantee you that 750 milliliters is going to cost you between 60 and $80. When you get a 3-liter 10, you're getting way more than 750 milliliters. Think about that. You're saving a ton of money and getting the real deal. You'll get all the good polyphenols and everything else you get from olive oil at Villicapelli. Put in promo code Vinnie at checkout and you'll get 10% off every single time. Villicapelli, 10% off every single time. We're talking to Dr. Laura Buchanan. Folks, if you ever want to hear some great back shows, if you go back and listen to the catalog, Laura and her husband, who's also a medical doctor, it's Matthew, right? Matthew Calkins.
Yeah.
I always want to call him Macaulay, but Matthew Calkins is her husband, and he's also a doctor. It must just be amazing. 2 doctors, same house. Your kid is going to grow up with so much incredible knowledge. It's ridiculous. Years and years and years ago, Laura, and I'm going back to the 90s. This woman wasn't a friend of mine, but she was an acquaintance. I guess we could call her that. So, look, folks, don't go say, oh, your old friend, Suzanne Summers. No, we weren't friends. I met her husband once or twice. He's still around. Suzanne passed away. But Suzanne was early money on using DHEA. wrote books about it back before we had the computer. Books, you get on DHEA right now. Now, I know nothing about any of this stuff. I do know that, I used to talk to doctors about it, and they were like, well, your body has a ton of DHEA. It's a hormone that's somehow in your body. Maybe you can explain more about it. It's in your body when you're like 12 or 13 or 14, you have a ton of it. And as you age, it goes away. But if you replace this DHEA, apparently a lot of your problems go away. I don't know. I'm not telling you guys to take it. What do we know about women, DHEA, and sex hormones and just hormones in general?
Yeah. So when it comes to DHEA, the studies overall have not been that promising. There has been some studies that showed slight decreased anxiety from supplementing DHEA. It's very interesting that DHEA is an over-the-counter supplement, whereas other hormones are prescription, and testosterone is actually a controlled substance, which I think is another issue. But DHEA, you can just go out and buy as much if you wanted it on Amazon.
Yeah.
And so the DHEA is broken down into a couple of different things, one being testosterone, another being estrogen. And so in the body, you take a DHEA supplement, some amount of it's going to get turned into testosterone, some amount will get turned into estradiol. And we actually don't know what the body decides to do with it. So that's one of the reasons, besides the fact that the studies are kind of mixed and showing benefits, but I would just prefer to use estradiol and testosterone, which have shown much more positive benefits. And I'm better able to control the quantities and the amount of what's happening. Whereas with DHEA, again, I'm kind of leaving it up to the body to decide what happens.
But wouldn't the body, we don't know this, and I'm not asking you, I guess it would be conjecture for you to even answer. If the body needs estrogen, maybe it turns it into estrogen. If the body needs testosterone, it does that. Or does the body just take this junk? They used to call it a junk hormone. That's the way I used to hear it, right? But we don't know what the body's going to do with it, right?
Yeah, we really don't know exactly how it's going to get broken down. And again, with the studies in postmenopausal women to try to treat their symptoms, it just has not been shown to be as near as effective if you just use estradiol. There was a study in premenopausal women who are on birth control, and birth control pills actually decrease testosterone significantly, up to potentially 50% in women. And so giving DHEA actually it was a small study, but in that study brought those levels back to normal. So again, there may be a role for it. I don't use it that commonly. I do have a few patients on it, and we're just monitoring hormone levels, and they're feeling well, so we're not, rock the boat. There is a vaginal DHEA that for some women can be really helpful, especially if intimacy is painful. And that's because, again, we have both estrogen and androgen receptors all throughout our pelvic area. And many women just as we get older, but then postmenopause, our testosterone levels drop significantly as well. And so if you use vaginal DHEA, you're not only getting estrogen back, but you're getting the testosterone back. And so that can really mitigate symptoms very similarly to vaginal estradiol. So that can be something especially to consider if a woman is still symptomatic on vaginal estradiol.
Yeah, I do a thing. I doctor Google things sometimes because people, if I start hearing stuff in the phone calls, I'll go, all right, let me just go read a few studies. And of course, I'll read whatever the NIH has to say, and I'll go read, just a few of the ones that you want to trust, or at least. And a lot of times I don't know what I'm reading because it'll go over my head. But whenever you read DHEA, they'll even tell you in some countries like Canada, it's illegal. You cannot get it without a prescription, right?
Yeah.
And here, as you said, you can just go to Amazon and buy all the DHEA you want. And good luck knowing if there's DHEA in the bottle or not, because
Right.
I own a supplement company, and I mean, some of these companies can lie to you about everything. But the bottom line is that some of these studies have shown with elderly men, right, that DHEA has been shown to help them, and in some cases with women. And I did read the thing about the estrogen. You don't know if it's going to go to the estrogen receptors or whatever. So it is all over the page, but you would think that there would be more studies. And the other one, is it pregnenolone? Is there something called pregnenolone, or am I making that word up?
Yeah, pregnenolone. Yeah.
And that's another one, that comes up. Should I take pregnenolone? But the thing, you mentioned something that made me think about reading those studies. I just thought, okay, it's a junk hormone, DHEA is, and it doesn't really matter. And pregnenolone, if it did anything, they would actually take it off the market. These are the things I think, right? And then there are big time warnings. If you want to take testosterone, you must go, you need to clear, not just go off of DHEA. There needs to be like a clearing out period. What do you guys call that? Like a
A
washing out period?
washout. Yeah.
Yeah. And I'm like, well, obviously this drug is doing something if they won't give you testosterone unless you clear out the DHEA or wash it out.
Yeah.
Any thoughts on any of this?
So I haven't actually looked into as many studies on DHEA in men, so I can't really talk too much to those studies. I haven't had any of my patients yet who were male that were interested in DHEA, but the from a washout perspective, honestly, there's, again, because maybe if you're trying to titrate their hormone levels, and if you're giving DHEA and testosterone, you really don't know what their baseline testosterone is. If their testosterone comes back at 40, is that coming from the DHEA? Is it necessary to give a washout if they're on a low dose of DHEA, which, again, there's doses, you see people taking wild ranges on the internet. But if you're taking a low dose of DHEA, I have stopped people and just started them on testosterone, and there's been no issues, and I don't see a physiologic reason that would be problematic.
Yeah, that was the other thing. When you read these studies, they'll say we gave them 50 milligrams of DHEA, and then you'll go read something else. It's like, I take 400 milligrams of DHEA every day. And it was like, wow, that's 10 times, almost 10, that's 9 times the amount, right?
Yeah.
And you're sitting there going, what is it? Where are we on this? Right?
Yeah. I mean, and that's when it comes to pregnenolone, that's another, in the pathway, it can get broken down to progesterone. It can go down this other pathway to get broken down into DHEA, which again, then that can get broken down into androstenedione, testosterone, estrogen. I mean, it's kind of higher up on that pathway, and there's so many different routes for it to take that, I prefer not to do that. And, maybe the body would choose the optimal route for you, but I don't know. And it's hard to measure that.
Are there any of these, I don't even know if it's a real word or if it's an internet bro science word. Are there any of these precursors that men or women should look at that might actually work? Or is it all take the actual thing or leave it alone?
I think honestly, there has not been adequate studies. Maybe there could be some benefit that we don't know about, but there just have not been large studies. And that could be from the pharmaceutical companies, they're not putting up any funding for that. And the supplement companies, they might make the product, but then they're not doing any studies to really back that up. So
yeah, it's the information is just so spotty. And that's why, like I said, if I hear something twice a week on the phone calls, I'll write it down. I keep things jotted down on pieces of paper. And when most people are watching television at night, I'll go, all right, let me go look up this pregnenolone thing, and, you go look it up and it's like, no one should ever try to take this, or, yeah.
Yeah, I tend to agree with that there. And the same thing, some people anecdotally, or I've read, they find benefit for their hot flashes from black cohosh or something, some other kind of supplement. But for the most part, the studies show it's really no different than a placebo. Almost most of the supplements that are sold on the market to help women with their menopausal symptoms. And so again, that's where estradiol it is shown it is by far the most effective, can basically take the symptoms away. And so again, if someone wants to try a supplement first, we can do that route, but the studies really just don't back it up. And the major menopause society, the organization, same thing. There's cognitive behavioral therapy might help hot flashes a little bit, but otherwise, it's really hormone therapy is the most effective. There are medications, but those come with much more side effects typically than you have to worry about with hormone therapy.
Final thing I want you to talk about, I want you to go back to something you said earlier, these bioidenticals. All right. So they're made by the drug companies, right? These are not made by supplement companies or
Yeah. So it's the pharmaceutical companies or compounding pharmacies. And so if you go the compounding pharmacy route, I would just encourage you to find a compounding pharmacy that does check the quality of their products. They have special certifications, and there are compounding pharmacies that are very tightly regulated, and they do have these extra certifications, and it's, I would say, just as good quality as the pharmaceutical company. And so for some women, for example, micronized progesterone has peanut oil in it. So if you've got a peanut allergy, you can't take the only bioidentical progesterone on the market. So
Right.
you have to go to a compounding pharmacy. And so there's definitely a time and place, and I do use the compounding pharmacy fairly regularly to help patients kind of optimize dosing, because with the pharmaceutical doses, you're kind of stuck with it. But the pharmaceutical bioidentical, they have transdermal patches that is estradiol, the bioidentical form. They actually have an oral estradiol, same thing. And then same with the gels, or the gels as well, that's also bioidentical.
Good. Will you ever go into doing the male side of this, or is that just something you're not interested in?
So I actually do have a handful of patients, males, that I am doing testosterone replacement for. I just have not, I would say, done the extent of the research I have from the female standpoint. So there's, many other people I've listened to on podcasts that are fantastic and can tell you every nitty gritty detail about testosterone replacement for men. But I do have a couple of men who are doing really good on their testosterone replacement. And so I think it can, just like it can be life changing for women, I've seen some really good results for men as well.
And how does that work? Is that shots, or like I've known guys, I have friends, right?
Mm-hmm.
Some guys they're putting clear gel somewhere on their body, and
Yeah.
some guys are. You mentioned the pellet. Um,
Mm-hmm.
I knew a guy doing the pellet. Um, I guess are there shots? I mean, I'm
Yes, yes,
in the woods on this
yeah.
stuff because
So
I don't take any of it. Although people accuse me of it, which I love, right? You
yeah,
know,
it's a good compliment.
you're
Yeah.
taking something, you're 63 and you don't have any fat on your body. It's like, nah, I'm taking life, baby. But
Yeah. So the two most common are definitely shots and gels. The shots, the frequency can actually vary a whole lot. So it's very commonly done once every 2 weeks. I don't love the once every 2 weeks, because typically you'll get a big increase, and then by the end of the 2 weeks it's dropping down, and so you're a little bit on this roller coaster. Just whereas if you're doing it once a week, and some people even actually do it once every 3 days, then you're getting a more stable level in the body. That's the idea of the gels as well, is that if it's a gel you apply every single day, that you'll have much more stable levels. For some people, because of skin absorption or whatever reason, the gels sometimes don't work as effectively. And so sometimes if you're not having any benefits within several months of the gels, or you're repeating levels and their levels aren't changing, then you can transition to the shots, and they may get more benefit from doing that.
and the prostate problem. I've seen, oh, it'll give you prostate cancer, and other people will tell you, oh no, it'll stop prostate. You see, that's the
Yeah.
problem with all of this stuff. Depending on who you want to listen to, and both people can be like a urologist, and one will go, oh, you take that, you're heading straight down the road to a Gleason score of 10, and
Yeah.
someone else
Yeah.
will go, oh, you can have a Gleason score of 10. Take this, and your cancer will go away. Where are
Yeah.
we at? What should we
Really.
believe?
Yeah, so it does not actually look like testosterone replacement increases prostate cancer risk. Even if someone has prostate cancer, sometimes they can actually get testosterone replacement therapy. Now, if they have metastatic prostate cancer and they're on androgen deprivation therapy, so they're trying to drive that testosterone to the floor, you're not going to replace it during that.
Right.
But otherwise, you still actually can. And the other concern besides prostate cancer, which is, again, kind of probably been blown out of the waters, was heart disease risk. That used to be something that was brought up.
Mhm.
But earlier, so this year, last year, there was a 5-year study that basically showed testosterone replacement did not increase cardiovascular risk. And that year, when that study came out, the FDA instantly removed that warning from testosterone for men. It does not increase
Really?
cardiovascular risk. I wish we had that kind of response in women's health from the FDA, but I don't know why there's that discrepancy there.
Yeah, it seems like anything to do with the male penis. Well, it's the only kind of penis there is. There's no female penis. Um, we're quick, right? You can get a blue pill, you go to Cialis, get whatever you want right away. It's got
Yeah.
something to do with men and erections, and boy, here we go. Hey,
Yeah.
men, you wanna not only get more erections but feel good again? We're going to take that black box label right off. Have all you want. Women, we'll take a look see when we get some time. It's kind of crazy, right?
Yeah, it is. There is so during one of the things that can happen during or post menopause, there's a structure in the female anatomy called the labia minora, which can just basically go away with menopause. It can just regress. And
Right.
that tissue is extremely sensitive and helps with arousal, helps with orgasm quality. And if you actually use vaginal estrogen, you can help prevent that from going away post menopause. But imagine if there was, when men hit a certain age, all of a sudden they had their penis started shrinking just like the labia minora started shrinking.
Yeah.
Just like you said, there would be such an outcry that would be fixed to be solved. The problem would be in no time we would have an answer.
Oh, yeah. Yeah. We would, every wars would stop everything. We would be working on this. Every man around the world would just be working on one thing. We got to keep our penises big. Come on, guys. Let's come together. We can start having wars again later on. Well, Laura, I would love to keep you forever. I know you, and we have to wait for this to upload, so I'm going to have to keep you for a few more minutes. But thank you for coming on, because this is one of those subjects that just keeps coming up. And Tro goes, "Yeah, I tell you, talk to Laura." I'm like, wait a minute, I didn't know Laura was doing all that stuff. Like
Yeah.
weight loss.
I
So,
love talking about it. And if I had, actually, there's two other quick things I'd like to just bring up.
oh, absolutely.
So one, when I was talking about the FDA indications, one of the other ones, the last one I didn't mention, is it is approved for the prevention of osteoporosis. And
What
women,
is
estradiol, hormone therapy for women, is actually approved to
the
prevent
one that you
osteoporosis.
put in the vaginal? That one, or
No, the systemic hormone therapy.
okay, all right, great.
Yeah, you got to increase blood levels. So estrogen is incredibly important for bone density. So women will lose 12% of their bone density through that transition. And 1 out of 2 women over 50 will have a fracture from osteoporosis. So
Mm.
this is a huge issue. Hip fractures are an incredibly increased mortality. If a woman has a hip fracture, her mortality within 20%, if she's over 65, or if she's over 65, she has a 20% mortality in that first year. And 25% of women will require long-term care after a hip fracture. 50% will never have the same mobility. And the WHI, even in all of its flaws, showed a 33% reduction in hip fractures. And bioidentical estradiol, there's been even better benefits in a prevention standpoint from fractures. So this, I mean, that by itself, because it's prevention of osteoporosis, makes every single woman in the United States qualify for hormone therapy if she would like.
Wow. Wow. So women, you heard it. If you want to get this stuff through your insurance, you can. I mean, that's basically what we're saying here, right?
Yeah.
Yeah.
Yeah. And if you start it, the closer it is true, the closer you start it to menopause or the perimenopause transition, the better the data is on benefits. There's actually data for decreased all-cause mortality, which there's no other medication that shows decreased all-cause mortality. There's decreased cardiovascular risk. There's, again, the fracture prevention, decreased diabetes risk, decreased depression, anxiety, and then all the other genitourinary symptoms we discussed.
Yeah.
If you start it after 10 years, you can still have a lot of benefits, but we don't see the same benefits in all-cause mortality or heart disease. You aren't at an increased risk, but you don't see those benefits.
Interesting. Laura, where can they find you? Are you taking patients online, or how does that work?
Yeah. Yep. So we're taking patients currently almost in all 50 states now. Only 2 states we're not taking patients are Alaska and Hawaii. And I'm on Twitter at Laura Buchanan, or X at Laura Buchanan MD. And you can go to tord.health to find out more information about our practice and if sign up and become a patient. Right now, we also actually have a big discount. So if you do sign up, you get $500 off your first year. So now would be a great time. We'd love to see you, help you change your lifestyle. And maybe if the time is, it's during this time of your life, maybe you do hormone therapy as well.
Go check it out. Go check out Dr. Laura Buchanan at Toward, TOWARD.health. and she will give you a consultation. You'll see if it's for you or not. And look, I'm a guy who's trying to get people off of medication, but if this can help people do better, why not? Right? Uh,
Yeah.
we all have to make a decision. So go and check that out. Folks, you know what to do with me. We all go to Amazon. Before you go to Amazon, go to VinnieTortorich.com, click through the banner. It puts a little coal on the fire, gets my train down the track. I mentioned Pure Vitamin Club during the show. Go to PureVitaminClub.com. Also, PureCoffeeClub.com. Go to PureCoffeeClub.com. Everyone agrees that coffee is one of the healthiest things you can drink, right next to H2O, right next to water. So go to PureCoffeeClub.com. That's my company. I make the purest coffee in the world. On behalf of Dr. Laura Buchanan, my name is Vinnie Tortorich. Put life into living and do it with enthusiasm.